I would like to thank our speakers for their wonderful talks this evening. I would like now to invite them all to join me before the break to address questions from the audience. Dr. Salama and Dr. Al-Fayh. So some of the questions I had so far, I'll start by the first question to Dr. Brown. Do you believe that the addition of anti-CD20 has made acalabrutinib more effective than ibrutinib?
So, you know, I do think the data with obinutuzumab together with acalabrutinib look quite encouraging. We do have data with obinutuzumab together with ibrutinib, which don't look as much better than ibrutinib data as this does compared to acala, but the patient population was different. The Illuminate patient population included a higher rate of P53 and 17p deleted patients, and there was no head-to-head comparisons to single agent. So it's hard to tell. But right now, I think that it does look encouraging that the acalabrutinib obinutuzumab combination may be potentially more potent than ibrutinib. Although, unfortunately, we're not going to have frontline head-to-head data. We only have relapse data. And we need longer follow-up of that trial as well, which hopefully will be forthcoming later this year.
Okay. The next question is for Dr. Al-Fayh. Do you think there is potential for human errors, as there are huge information we will need to input into the artificial intelligence machine to analyze the data? So who should actually input this information, and whether this could lead to human errors?
So thank you, Mohammed, for that great question. So in deep learning, the extraction of the data should be automated, different than the machine learning. So definitely the quality of the output of the machine learning depends on the data itself. The quality and the size is very important. So the outcome depends on the input.
Okay, the next question is for Dr. Salama. So you have shown us amazing studies that made us think that, is it really time to go back to basics and rely on basics tests? So like peripheral blood film and smear, showing very high sensitivity in predicting specific diagnoses and differentiating one from other. Is this going to make us do less of the confirmatory advanced testing, or are we going to do them with confidence, or what?
Yeah, I think that's a great question. I think to answer this question, we have to go back to actually the previous question, again, which is the value of the output or the input. 80% of the AI study, 80% of the effort is actually depending on the input or the annotation of the data. And it have to be very well data and the question that's answered. Now, I may be able to, we want to make sure we don't over interpret the results that have been done so far, because what I have shown is the promise of the AI. But I would not go in a clinical practice and say I can diagnose MDS from a peripheral blood study, because as I showed you also, the more you are going to add additional variables, then it becomes, the system becomes challenged. So we still have a long way to go. I think where we have reached in terms of gold standard of NGS or immunohistochemistry or double expressors or outcome, and at the end of the day, the clinical outcome is the gold standard, is what we refer to at the end of the day. But we still have a long way to go. I think there's going to be a lot of utility of it in the short run on a smaller scale operation, then eventually able to address some of that. But there is no question in my mind, in 5 to 10 years, we are not going to be practicing medicine the same way we are practicing it today. I'm just talking from a lab perspective. And obviously, what we will give you as a clinician is going to be different.
Okay, there is also another question for you, Dr. Salama. With now artificial intelligence, are we able to make it do more of not only a confirming one test, is more of a summation of multiple tests to lead into one diagnosis. So combining peripheral film, staining, flow, all together in one report, genomics.
Yeah, I think that is correct. So then once we, as I said, we'll start doing this in one area, but then we'll have success here, success here, success here. So when we do flow cytometry, for example, we have we have to look at a slide and then decide which tubes will be ordered. So if I have an algorithm that can tell me the cell that now they can call the blast faster or give me more features that I didn't know before in the blast, that's predict p53 mutations, for example. And then eventually I would have the molecular, I can order that test. And then I have the flow data that actually confirms that this patient likely belongs to these. So now we're going to have an integrated report that's more standardized, that's more actually predicting the outcome. Chances are it's going to be predicting the response as well, because we are not going to be anymore trying. I mean, we may be able to say this patient is likely to respond to this therapy and not that therapy. So with the multi-modality integration, as we have more success in this is really where we are going towards. What we still have a long way to go, but what I showed you again proves that this is achievable.
So next question is for Dr. Brown. Ibrutinib and the other the other drugs from this family has almost transformed the face of how CLL patient respond to therapy. Are we going to make these cardiac complications potential showstoppers given the patient population? Have you seen any studies coming for like co-prescribing medications that could maybe minimize or alleviate these complications?
So I'm not aware of any studies that have pre-planned, for example, adding antihypertensives with ibrutinib up front, or is something that might prevent, for example, the rare ventricular arrhythmias. But we've had several deaths in our practice from those, and so have most other people who use a lot of ibrutinib. Honestly, I think that the cardiac complications are significantly less with the other two drugs, acalabrutinib and zanubrutinib, and I think that's how we're going to get around it. There was a recent paper published in Circulation in December that identified the off-target for atrial fibrillation as CSK, which is inhibited by ibrutinib, but not by acalabrutinib. And in fact, in their mouse studies, they were able to show that acalabrutinib did not induce atrial fibrillation in the same way that ibrutinib did. And when you knock out BTK, you still got atrial fibrillation with ibrutinib, because it was not dependent on BTK. It was really a very nicely done study. So I think the way hopefully we'll avoid this problem is that we'll move to the next generation drugs that don't have the same problem.
So given the huge effect of say BTK inhibitors or the new generations of CLL therapy on the disease, this is a question for Dr. Brown. Do you actually think that the fact that we see the effect of 17p deletion clone happening later is just because of the dynamic of the disease, because it's an indolent disease, or it's truly the effect of the selective pressure of the prior regimens on the other clones as the disease progresses?
Right. So I think that there's ongoing clonal selection even during ibrutinib therapy. We have a couple studies showing that there is, in fact, evolution during ibrutinib therapy. It doesn't select for 17p quite as strongly as chemoimmunotherapy, but it does to some extent select for 17p. And I think we'll see the same thing with venetoclax, that we may not get induction of new mutations like we did with chemoimmunotherapy, and the selection may be a little less strong, but that more or less as we move from therapy to therapy, we're still going to see selection of resistant clones. Also, we're trying to understand new resistant clones, right? These BTK mutations actually often confer aggressive behavior on the CLL, even if there's no 17p deletion. And we don't really know what the natural history of that will be, for example. Other than that, we do know that patients who've progressed on ibrutinib treated with venetoclax have a much shorter progression-free survival than those who haven't progressed previously on it. So I think our clonal evolution problems may just be a little bit different, but that they're still there. Well, unfortunately, it also probably will be later times than before, so we'll have longer treatment intervals before the clonal evolution problem.
So now with the, this is again for Dr. Brown, now with the MRD testing, we are seeing those studies are doing a lot of bone marrow testing on patients. Most of hematologists, they don't do a lot of bone marrow testing on their patients. Will that become a mandatory if patients are on BTK inhibitors throughout, or only to decide when the treatment is completed or cessated?
So MRD testing has actually very little value currently for patients on BTK inhibitors, because almost everyone on BTK inhibitors has only a partial remission, not even a complete remission. And undetectable MRD is vanishingly rare. So patients who are continuing on the BTK inhibitor, it doesn't really matter if they have some residual disease. Where we use the MRD testing is really more with time-limited regimens, so the venetoclax combinations, because there, the achievement of undetectable MRD when you stop the regimen is strongly associated with your subsequent duration of response and progression-free survival. In terms of the bone marrow versus peripheral blood question, I think most of us who do a lot of MRD studies and study it do think that it is a little bit more sensitive in bone marrow compared to blood. But you will notice that many of the randomized trials have specifically evaluated blood as the endpoint to predict outcome, so that you don't actually have to do a bone marrow. And the data increasingly suggests that whether or not you're in complete remission, which obviously requires a bone marrow to prove, is not as important as your MRD status. And the peripheral blood MRD status is almost as predictive or similarly predictive as the bone marrow. So people won't really probably have to do them.
Okay, so the next question is for Dr. Al-Freih. Do you think with ongoing evolution of artificial intelligence, we will be using such platform, hopefully with no technical barriers among countries, so we can reach for expert set of eyes or center on rare cases to help us reach diagnosis or help us analyze an algorithm to reach for a diagnosis for expert opinion overseas?
Thank you, Mohammed. So I agree with that. Actually, this is one of the advantages of AI and machine learning, is to augment the lack of, highly skilled professionals. However, there will be some shift in the highly skilled professionals. So, for example, now the current situation, we are looking for a physician who is expert in X disease. Probably in future, we will be looking for an AI expert in interpretation or looking to the data. So there will be definitely a still need for highly skilled professionals, but probably there will be some more shift toward those who have the skills for artificial intelligence and machine learning. Thank you.
Okay, and for Dr. Salama, my next question is, do you think where artificial intelligence, or I will actually borrow your terminology, augmented intelligence, is actually going to actually help us define or determine which patients are going to receive certain tests? Like, for example, just for simplicity, is bone marrow indicated in patient A or not? That's the first part. And then the second part, can a specific flow or algorithm, say your lab developed, can actually help, for example, my lab reach a certain diagnosis through a certain stain? So such systems or algorithms can be shared among centers?
Yes, I think the short answer to both of your questions is yes. And I honestly think it's going to be even more than just doing the peripheral smear. Going back to my point, AI is beyond imaging. So you, in a patient with anemia, you would be able to look at his anemia and the lost or progression of his anemia in the last 4 or 5 years just from a CBC punch in the numbers into an AI and can tell you with a very high level of confidence the 17 parameters from a CBC combination, this patient had 99% chance that become an MDS or something else. And then then you can decide on what additional testing to confirm. This is really what I likely expect things to be in the future. With regards to I think really AI is gonna help you in terms of intervention as a clinician. Now, this intervention could be another test or could be another therapeutic, depending on the testing, the question that's asked. We need to start with the low-hanging fruit. So if it's in your practice, you have a problem A, then this is where you start to look at the tools you have and maybe develop what would answer your practice that benefit from that, because the spectrum is so big. Now, going to the second question, what I just mentioned now, the reason why I mentioned this, because if you develop something in King Faisal or in King Saud or King Abdullah Hospital, I mean, whatever you have developed for your practice now, others in other country can use it. I don't have to, I may develop things are specific for my practice, but because of the connectivity, because telepathology, because of the AI algorithm itself, you can scan the slide across the globe. I can apply my algorithm on it, and then you can benefit from it. So you don't have to develop it itself. So I think this is where sharing of knowledge and sharing information, because now you don't have to share the data, but you share the tool that can be applied on a data and serve others. Hopefully this answered your question.
Thank you so much. Maybe we have a room for one final question for Dr. Brown. I don't know if do you use this in your practice, using the value of beta-2 microglobulin to determine dosing for BTK inhibitors?
I don't use it to determine any dosing or even to decide on treatment, but I do monitor it as a sort of general evaluation of the patient's status in terms of their overall disease burden.
Okay, with that, we will conclude our question and answer period. Thank you very much for everyone, our audience, our speakers, for augmenting this day of the conference. So at this point, it will be now the break where we can actually start and explore the virtual exhibition of the conference. It will start from now until 22:30, and then after that there will be another break, and then we will join back for the second part of the day. Thank you so much.